I'm going to talk about some of the data we've obtained during a clinical trial on BBB opening in glioma patients. Some disclosures: we have received funding from Inside Tech, and they also supported this trial. So these are some data obtained at our site from a multi-center trial looking at temozolomide delivery via BBB opening, adding to standard of care for patients with newly diagnosed glioma. It's a multi-center trial, and the PI is Graham Woodworth at University of Maryland. The results of the trial are going to be shown at a later date. I'm going to talk about some data that we've obtained in addition to the trial, looking at contrast enhancement in T1 weighted fast spin echo imaging, petechia in SWAN imaging, cavitation data obtained by the device, and also doing some acoustic simulations of these treatments. This is from 9 patients. The treatment itself was targeted in the flare hyperintense volumes that are surrounding the resection cavity. For each sonication, the device steered to up to 32 subspots per sonication. These are 5 millisecond bursts. The total sonication duration was about 3 minutes. We were using a very low dose of microbubbles due to the FDA limits at the time of the trial. So in this treatment, we took 20 microliters per kilogram of Definity and diluted that in 250 milliliters of saline, and that was infused via an IV drip over 80 minutes. And if you compare that to what we historically have done in preclinical trial studies in animals, typically we give 10 to 20 microliters per kilogram as a bolus injection for every sonication, and some people use much higher. So this is a lower dose of Definity than what we typically use. The controller of the device used subharmonic emissions to control the acoustic power level. They defined a cavitation dose, which is the sum of the submissions around the subharmonics with multiple detectors. Initially, during each of the sonications, where they had up to 32 spots, only one power level was controlled, and that led to variable dose. Later treatments, they had spot-by-spot control to give a more uniform dose. Looking at the analysis, I registered all of the MRI to the same reference frame, and using the treatment logs, defined regions of interest every subspot, and use that to also look at the combined targeted volume. For BBB opening, we did this in contrast enhanced T1 weighted imaging. This was automated using a low level of enhancement to say whether or not the BBB was open. And for petechia in SWAN, this was done by manual segmentation. These are the volumes that we treated over these 9 patients. We did 37 treatments. The smallest volume was around 2 centimeters cubed, and this was in a patient that couldn't tolerate Definity. He appeared to be allergic or something to it, so we had to abort those treatments. And the largest was about 40 centimeters cubed. You can see initially, as we were learning, we treated larger volumes with each treatment, and then later we targeted similar volumes for consistently over the treatments. Here's some examples of the volumes that we treated. This was 6 treatments in 1 patient. The green volume was where we targeted, and then the blue volume is a mirrored volume in the other hemisphere as a control. And you can see that we were getting BBB opening in the targeted area. And if you look more closely, we can see that this opening did a good job of covering the entire volume. Looking at the level of signal enhancement, the level of opening was fairly low during these treatments. But it was larger than in the non-targeted areas significantly. So at every treatment, we achieved BBB opening when we looked at the entire treatment as a whole. Looking at the percent of the volumes that we had BBB opening, yes or no, this is in blue. And then we also did the same analysis for petechia in SWAN, which is red right after the treatment, and then black is if those hypointense areas from petechia persisted a month later. And you could see when we first started, we had higher levels of opening, but we had more petechia than we want. So we used lower dose goals, and by the last patient, you could see that we were getting opening consistently with little or no petechia. To look at this more closely, I performed acoustic simulations with K-Wave. To do this, since we had so much beam steering, we simulated each element of the transducer separately. And then in the computer, we could add magnitude to phases so that we could get beam steering and aberration correction. And at this point, I've only looked at longitudinal mode. I haven't looked at shear mode. Some results. This was in one of our patients. One of the treatments in one of the patients, we could see that this was before we had spot-by-spot control. So the cavitation dose here in the middle was not uniform, and that mapped well with the pressure amplitude that we simulated. And that also agreed with the contrast enhancement after the treatment. In the next treatment, we got the spot-by-spot control, and you could see that we had more consistent cavitation dose opening that covered the entire volume. But we also continued to see this higher pressures in the similar locations, and that was actually reflected in the enhancement as well. This wasn't always the case. This was another case where we had higher cavitation dose values, high simulated pressures, but very low level and spotty BBB opening in this treatment. Looking at the data overall, these were for the 9 patients. The individual dots are measurements in a single subspot. And you can see as the simulated pressure increased in several of the patients, you could see a clear relationship. This was sort of a messy measurement because we had overlapping targets, so one spot could interfere with another. But you could see the trend was in several patients where we increased the pressure, we got more of the BBB, larger percentage of the volume had BBB opening. However, in some cases, these 3 patients, 1, 2, and 7, we could see as we increased the pressure amplitude, the controller wanted to use higher pressures, but we got less opening. This might be related to differences in perfusion or vascular density and the lower microbubble concentration. Looking at the cavitation dose, you can see in most cases, as we increase the dose, we got more opening, but there was a lot of variability. You can see here, in patient 4, we had a high level of opening at this cavitation dose, but in patient 2, it was less. And in the cases where we saw high pressure amplitudes with less opening, that was not reflected in the cavitation dose. But in some cases, in many of these patients, we had very narrow ranges of cavitation dose, so we didn't see a clear relationship. When I lump all of the patients together, excluding those patients where we had high simulated pressures with little opening, we could see that there's a clear trend between both the pressure and the cavitation dose, with BBB opening in green. Blue is BBB opening using a higher threshold of enhancement to say that BBB opening occurred. And when we use those higher thresholds, it seemed to line up more with what we saw with petechia. We can compare this to thresholds that we found earlier in non-human primates with this device. And it looks like we're perhaps getting BBB opening at lower pressure amplitudes than what we saw in the monkeys. This could be because I'm not including shear mode and I'm underestimating the pressure amplitude. So to conclude, subharmonic emissions were correlated on average with both BBB opening and petechia for individual patients, but that correlation was less clear when considering multiple patients. We need to consider additional factors to improve outcomes, perhaps looking at the effect of the skull and the locations of the focal points and the cavitation detectors, mapping vascular density or blood volume to estimate local microbubble concentrations, and perhaps considering more of the spectrum than just the subharmonics. I'll stop there, and I'd like to thank the funding sources and the rest of the team. So thank you.